recorded, and the recording will be made available to everyone on the YouTube site later on. Okay, so I'd like to start with some disclosures. This activity is jointly provided by Cardia Services and the United South and Eastern Tribes. Cardia Services is approved as a provider of continuing nursing professional development by Montana Nurses Association and accredited approver with distinction by the American Nurses Credentialing Centers Commission on Accreditation. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the California Medical Association through the joint providership of Cardia and the United South and Eastern Tribes. Cardia is accredited by the CMA to provide continuing medical education for physicians. Cardia designates this live web-based training for a maximum of 1 AMA PRA Category 1 credits. So if any of you want that, I will be sharing the link towards the end of the hour. You do have to complete an evaluation in order to get the continuing education credits. A couple more disclosures. Okay, so completing this activity to get credit, it will count as 1 contact hour, and successful completion of the continuing education activity includes the following: attending the entire hour, completing the online evaluation, and submitting an online continuing education request. If you have any questions about the CE activity, you can either send them to us and we'll forward them to Kyla Natale, or you can send them directly to her. And lastly, Dr. Brown's partner owns Stock & Johnson & Johnson. No other planners and presenters of the CE activity have relevant financial relationships with any commercial entities pertaining to this activity. All right.
And actually, Emily,
yes,
that's no longer true. My wife sold that stock about 1.5 years ago, so that's old news.
that is old news.
Yeah,
Okay,
sorry.
doing that slide. Yeah, and everyone, I'm so sorry I didn't introduce myself. My name is Emily Field, and I'm an evaluation specialist here at the United South and Eastern Tribes. If you haven't done so already, could you please share your name and tribal nation or intertribal organization affiliation in the chat? We're trying to see what kind of reach we're getting with these. We are being recorded, and we have 2 great presentations today by Emily Baer and Dr. Brown. And Emily, I have your slides, but I've also made you able to share if you'd like. Just let me know, what would you prefer?
Thank you. I think I'm gonna share my screen.
Go ahead.
Hopefully that is showing no notes, the appropriate slides. Thanks. So I'm Emily Baer. I'm a staff epidemiologist in the TEC, and I'm actually covering for Imani Ransby, which most of you are probably familiar with, who is also a staff epidemiologist, and she does our weekly COVID-19 reports. But I am going to cover her portion today as she's taking a much deserved day off. So getting right into it with our Nashville area COVID-19 epidemiology, the number of positive COVID-19 tests at reporting facilities in the Nashville area in the last week was 845. And that brings the cumulative total of positive COVID-19 tests in Nashville area to 12,440. Our 7-day positivity rate at reporting facilities is 29.5%, which is really high. It's increased a lot since our last echo session. I believe it was something around 7%, 7 to 10% on December 10th, but it hasn't increased that much since last week. It's remained pretty steady. It was 29% last week as well. So a lot of COVID in the area. And this is just a trend graph to show that increase. So down here was our last echo, where we were kind of remaining in the 70s range for cases by week. And it's increased quite a lot. So moving to new COVID cases per 10,000 in per capita areas in the states, USET states, and the United States. We have USET counties at 140 cases per 10,000, which is quite a drop, as you can see, from the previous week. And we think mostly that is due to data collection issues and backlogs with data, since the last couple of weeks have been during the holiday season or overlapped with the holiday season, as well as just staffing issues in general, getting data reported. So we're assuming that might be an artificial decrease at the moment. In USET states, there also was a decrease, possibly due to the same reasons, and the case rate is now 135.7. And in the United States, we see an continued trend towards an increase in cases to 165.17 cases this week per 10,000. So this is actually, this is part of our aggregate report. So some of you have already seen this, that goes out every Wednesday. And this is just trends in case rates per every USET state. You can see that there's a decrease with the USET all states rate, as we saw. And then there's a very sharp increases in cases for pretty much every state, except Florida, which is zero COVID approach seems to have worked great, I guess. And Maine, where we believe that backlog of data or like issues with holiday data reporting may be occurring. Maine did have a earlier wave than most Northeast states, so
I have
be part of the issue there.
Well, you do,
but there's an increase again, as we've seen.
Correct.
And now going into COVID-19 vaccination data on the percentage of the population who's fully vaccinated for reporting facilities in the IHS Nashville area in the gold on the left. You can see we're above half, which is great. So we're making some progress there. So we're at 51.5% fully vaccinated. And then for the United States as a whole, we are at 62.6%. And slowly increasing. So hopefully with the recent approvals of pediatric vaccinations, that will continue to grow. And then in the IHS, we have about 25% fully vaccinated. Then this is just showing the breakdown of vaccination rates per individual USET state. So once again, we have the reporting facilities in gold on the left and United States rate as well to compare. So a lot of states are doing great in terms of like slowly getting to pretty good vaccination rates with pretty high rates in the Northeast and in the South too. They've really increased a lot just since the fall. So this is actually great progress and hopeful that it will continue. And then this is a new slide that we've recently started to include. We want to track booster doses now that it seems more evident that they're really needed. So we are tracking the percentage of those people who are already fully vaccinated who are now getting a booster dose. And you can see in gold again, the reporting facilities rate is at 12.4%. And the United States rate is 36.7% at the moment. And then won't be going over every single state's rate, but we have a range between about like 22% to almost 50%. So that's good to see. And it looks like we've made a lot of progress just in the last week. You can see the cumulative totals in the blue lines as of last week, and you can see our progress in the gray bar in just the last week. So that's definitely good news. And this slide shows the percentage of COVID-19 vaccination doses delivered to states that have actually been administered. So it's a good metric of just how the utilization of vaccines and interest. And it looks like most of them are generally administered and not wasted or anything. So that's good. I don't think we have anything else. So I'm going to stop there if anyone has any questions. And I am actually going to close this screen.
Well, you'll have an opportunity to ask questions towards the end of the hour too, and feel free to ask them in the chat as well. And we can move on to Dr. Brown's. Let me share my screen.
Good morning, everyone. What I'm going to talk about today is therapeutics for COVID-19, and also do a short vaccine update. So if we can go to the first slide there, or I guess it would be the second slide, right? Thanks, Emily. So we are 675 days into the pandemic at this point. So I'm going to talk about several new therapeutic options. The first one being paxlovid, which is a combination of two medications. Also, I'm going to review Malnupiravir, which I did a few weeks ago, but I'll do it again. I'm going to talk about a new use for Remdesivir, cover some monoclonal antibodies, and then end with the vaccine update. Next slide, please. So, excuse me, hopefully I don't have COVID. I don't have any conflicts of interest now that my wife sold her Johnson & Johnson stock. The opinions I'll be expressing are my own, and if I make any mistakes, that's all on me. I am employed by both USET and Cherokee Indian Hospital Authority at the Eastern Band. So next slide. So the first thing I'm going to talk about today is the new oral medication that's out, Malnupiravir and ritonavir. It's a combination of two different drugs packaged as something called paxlovid. This has been in the news a lot lately because it was just granted an emergency use authorization right before Christmas on the 22nd of December by the FDA. So it's an oral drug for mild to moderate COVID-19 given to outpatients, not hospitalized patients, but outpatients who are at risk for progression to more severe disease. And I'll cover what that means a little bit later here. It's it can be used in people as young as 12, but they have to weigh at least 40 kilograms, which would be, what's that, 88 pounds, I think. So the active drug, Malnupiravir, is a new drug. It prevents viral replication by inhibiting the virus's main protease. You don't need to remember that. That's just for geeky people like me. The ritonavir, which is the other medication, it inhibits one of our enzymes in our liver that metabolizes the Malnupiravir. So it helps to increase the serum concentration of the Malnupiravir. Ritonavir doesn't really do anything to the SARS-CoV-2 virus that causes COVID. So the dose, this is given for 5 days, twice a day. And the nirmatrelvir, which comes in 150 milligram tablets, you give 2 of those twice a day and 1 of the 100 milligram ritonavir tablets. Next slide, please. So it comes packaged like this, picture on the right here. So it's got a morning dose and an evening dose. Nirmatrelvir tablets and 1 of the ritonavir. So how effective is it? Well, the clinical trial that involved a couple thousand people, in that trial, they gave it to people who were unvaccinated and were at high risk for having a bad outcome from COVID. And it was 88% effective in preventing severe disease, which was pretty impressive. During the trial, the Delta variant was the main one that was around. But according to some testing that's been done, it should be effective against all the other known variants, including Omicron. 12 people in the placebo group died. So these were actually high-risk people, and nobody in the treatment group died. So that's pretty impressive too. Now, unfortunately, there are several cons with Paxlovid, or cautions. And next slide, I'll go into those. If somebody has chronic renal disease, if their estimated GFR is between 30 and 59, you have to reduce the dose. You just take 1 of the nirmatrelvir tablets instead of 2. If their estimated GFR is lower than 30, you can't take it at all. It's contraindicated in those people. You also can't take it with severe liver disease. And unfortunately, it has many significant drug interactions, which I will show you on this next slide. This has a list of all the known drug interactions with nirmatrelvir and ritonavir. So all those that are highlighted in yellow are pretty common things that people take, especially people who fall into the high-risk category. So you really have to be very careful, review their medications if you're going to prescribe this, and make sure that you don't give them any kind of serious drug interaction. So the ones on the left there, those are ones that you really can't give at all with this medication. The ones on the right, you can give it, but you might have to change the dose on some of the medications. So hopefully you'll have a pharmacist who can help you out with this if you're prescribing it. Next slide, please. So now let's talk about a drug that I actually talked about a few weeks ago, Malnupiravir. This is also an oral drug for mild to moderate COVID in the same group of people, people who are at high risk for bad outcomes. This, however, is only okay to use if you're an adult, 18 years or older. The FDA gave it emergency use authorization the day after they gave it for Paxlovid, even though Malnupiravir came out several weeks before. That was kind of interesting to me that they did it that way. So Malnupiravir works a different way than Paxlovid. It also inhibits the viral reproduction, but it does it by introducing errors into the RNA replication. And that has caused some concern among a lot of scientists that Malnupiravir might actually induce new mutations that would produce a bad variant. The dose for Molnupiravir is 800 milligrams twice a day for 5 days. Both of these drugs, Paxlovid and Molnupiravir, have to be given within 5 days of onset of symptoms. And the earlier in the course you give it, the better. Next slide, please. So as I said, it comes in 200 milligram tablets. So you have to take 4 of these twice a day for a full, for 5 days for a full course. The clinical trial that they looked at to test the effectiveness showed that it was really only 30% effective at preventing progression to severe disease. Remember, Paxlovid was about 88% effective. So clearly it's not as effective. And again, Delta was the main variant that was around during the trial, but in theory, it should be effective against all the other variants, including Omicron. It was pretty good at preventing death. There was only 1 death in the treatment group, whereas there were 9 deaths in the placebo group. There are also some precautions with this drug, which we'll see on the next slide. You can't use it in pregnancy because it's been shown to cause toxicity to the fetus. You can't use it in under 18 because it affects bone and cartilage growth. It's okay after age 18. It's also mutagenic. That's how it works. It introduces mutations. These are probably not significant in humans, but there's the concern that it could make new variants of COVID. The good thing, the pros, it doesn't have any clinically significant drug interactions, and it can be used even in complete renal failure or with severe liver disease. So it has those advantages over Paxlovid. Next slide. So what's the bottom line with these 2 new drugs that really I think are going to be very important in our fight against COVID? Well, Paxlovid's clearly more effective, but Paxlovid has a lot of significant drug interactions, so you have to be careful with that. Also, Paxlovid can't be used with renal failure, complete renal failure, or serious liver disease, whereas Malnupiravir can. Both have to be given early, within 5 days of onset of symptoms. Both are also currently in very short supply, although the hope is that will change over the next few weeks as they ramp up production. So I would say that Paxlovid, is the more effective one. That's the one that you should use unless the person can't take it because of either liver disease, severe kidney disease, or they have, some kind of really bad drug interaction that would prevent the use. Next slide. So this is a drug that's been out now for a while. Remdesivir was FDA approved for hospitalized patients last year after it was shown to be effective at helping people that had COVID who were hospitalized. So there was a trial to use Remdesivir in outpatients before they went into the hospital. So they found that if you gave it within 7 days of onset of symptoms, it was pretty effective in preventing hospitalization. 87% reduction in hospitalization and death if you gave it within a week of symptom onset. The way Remdesivir works, it also blocks an enzyme in the virus to prevent it from reproducing or replicating. I shouldn't say reproducing. Viruses replicate. They don't really, well, anyway, that's a minor point. But anyway, in the hospital, you give it for 5 to 10 days, but they used it for 3 days, 200 milligrams the first day, and then 100 milligrams on day 2 and 3. Now, unfortunately, this is only IV. So to use it, you'd have to have somebody come in every day to get a 30-minute IV infusion. And similar to Paxlovid, you can't use it if somebody has severe kidney disease or they have really bad liver disease. But this trial was done in many hundred people, including, I think the trial, about 7% of the people in the trial were American Indians who were part of the Cherokee Nation out in Oklahoma. That was one of the trial sites. So it does have proof in our population. Next slide. So there are a lot of, so who would you consider these drugs for, as well as the monoclonal antibodies? Well, it's people who have a high-risk condition that makes them more likely to have a severe outcome for COVID. So people who are 65 or older, people who are overweight, pregnant people, people that have chronic kidney, liver, lung, or heart disease, current or even former smokers, people with substance use disorder, including alcoholism, cancer, tuberculosis, Down syndrome, heart disease, hypertension, diabetes, sickle cell disease, thalassemia, chronic brain diseases like dementia, and then anybody who's immunosuppressed for whatever reason, usually due to either disease or taking a medication. So it's a long list of things, would include quite a few of our patients. Hard to keep all of these in your head, so it's nice, if you have a list somewhere to refer to. Next slide. So let's talk about monoclonal antibodies now quickly. There are the two that were being used a lot have been found to be not effective at all, really, against the Omicron variant of concern, the Regencov and the bamlanivimab etesevimab. There is one monoclonal antibody, sotrovimab, that is currently authorized for high-risk individuals 12 or older, and it is effective against Omicron. Now, there is a new monoclonal antibody combination out there that I wanted to let you know about. It's called Evusheld. That's the trade name, but it's tixagevimab and cilgavimab. And it's just recently been given an emergency use authorization specifically for pre-exposure prophylaxis for certain individuals. And I'll talk about that on the next slide, who those individuals are. So these are two long-acting antibodies. They have half-lives of about 3 months. So they're good for about 6 months or so. It's given by an intramuscular injection. It's two separate injections. So one of the tixagevimab and one of the cilgavimab can be used in people 12 or older. Again, you have to weigh at least 88 pounds. And it is intended to be given to people who cannot be vaccinated for some reason, like they have a severe allergy to the vaccine. Or the other people that you might consider it in are people who have a severe immunocompromised condition and therefore would have a decreased response to the vaccine. The clinical trials showed it to be about 80% effective at preventing severe disease. It does have reduced effectiveness against Omicron. They're still not sure what the clinical significance is, whether it's going to still be enough to work against Omicron or not. So this is a sort of an interesting monoclonal or two monoclonal antibodies combined that has a fairly small kind of a small niche for use. But it is another therapeutic option that's now available. Next slide, please. So I'm going to finish up with just some recent new vaccine recommendations. Some of these are not so recent, like the EUA for the Pfizer-BioNTech vaccine for children in the 5 to 11-year-old age group. Recently, booster doses were recommended for everybody in the country who's 12 and older. There's a third dose now recommended for children in the 5 to 11-year-old age group who have an immunocompromising condition. So you give that third dose 28 days after the second dose. There's now a recommendation to give either one of the messenger RNA vaccines. That's the Moderna or the Pfizer-BioNTech vaccine. That booster dose can be given 5 months after the second dose rather than 6 months. Little shade of difference there. Also, just before Christmas, the Advisory Committee on Immunization Practices at the CDC came out with an actual recommendation saying that the mRNA vaccines were preferred over the J&J or Janssen vaccine. This was due to the rare but serious side effect that the Janssen vaccine has with the thrombosis with thrombocytopenia, that is blood clots that are sometimes fatal. Even though it's very, very rare, it is very serious. So the messenger RNA vaccines do not have that side effect. And that was why they recommended that unless you've got a really good reason to go with the single shot Johnson & Johnson, which would actually be 2 shots with the booster, the mRNA vaccines are preferred. You can read more about that on either the CDC website, or I've also listed a reference in the medical letter. You can get that for free, even if you don't subscribe, by going to that link. So next slide. This is just a vaccine comparison chart of the 3 that are currently available in the US. Remember that the only one for people under age 18 is the Pfizer-BioNTech vaccine. So far, the other 2 have not been approved in under 18-year-olds. A primary series consists 2 doses for the mRNA vaccines and just 1 for the Johnson & Johnson. If you're immunocompromised, you need an additional dose to complete that primary series. And then the booster doses are now recommended for everybody 12 and above. So next slide, please. I think that Emily Bear is going to talk more about this, but I've just quickly mentioned that the Omicron variant, there is mounting evidence that if you only have the primary series, you get very little protection against Omicron infection, but it still has pretty good protection against severe disease. But a booster dose does raise protection against both infection and severe disease caused by Omicron. There's also a lot more data on the Pfizer-BioNTech vaccine than the others regarding the Omicron variant. The next slide, I've listed a bunch of references if you want to go read this for yourself. But the bottom line is really what I just told you. And next slide, I think that's the end of my presentation. Oh, yeah, I forgot. There is something that I found inspiring that for those of you who take care of patients, if you're you know, a medical provider, a nurse, pharmacist, physical therapist, anybody who takes care of patients, I found this little short piece in the New England Journal to be kind of inspirational. You can link to it on the internet. It's even if you don't subscribe, it's free and available. But anyway, it's a really good essay, about a 2 or 3 minute read. I just found it inspiring and would recommend to any of you who want to read it. So that's it for me. I think if you have any questions, I'm always available by email or phone. The turtle is to remind us that this pandemic is a marathon. It's not a sprint. So thanks very much.
Thank you, Dr. Brown. Does anyone have any questions for Dr. Brown? If not, we have another presentation because I cut Emily off. And she will be discussing Omicron.
Really, we just took a break from looking at COVID cases, Emily, it's fine. So yeah, I'm going to be providing another update. This is more specific to Omicron. And starting just with a kind of an overview of US cases and like a state of the nation as far as hospitalizations and stuff. Talking a little bit about Omicron transmission and immune evasion. And then I also wanted to cover our new USET recommendations that came about because of all of this. Getting right into it, if anybody was on the IHS call we had yesterday, you've already seen this. Kirsty talked about it. This is looking at Omicron prevalence as a proportion of variants that are circulating. And you can see in the orange, we had a Delta dominance for quite a long time since the summer. And however, Omicron in purple has overtaken Delta in about a month. maybe a little bit over a month, so extremely contagious. Then looking at US cases by region, this breaks it out into West, Midwest, South, and Northeast. And they included Rhode Island as it has the highest per capita case rate as a comparator. But you can see every region has a strong, a spike in cases, a very sharp increase, and particularly in the Northeast, we have the highest per capita case rate here. If you zoom in a little bit, there's hope. It does kind of look like it is peaking. There's evidence out of like Boston and New York and some other big cities that we may have reached a peak, at least in the cities. So that's positive news for this region. Then going into cases by race, ethnicity, as I don't see this kind of discussed as much. This is weekly cases per 100,000. This data is from the CDC and it hasn't been updated recently. So it's through, it says January 8th. I actually think it's through Friday. And that is why January 7th. And that's why we have this weird decrease right here. But the positive information is American Indians and Alaska Natives do not have the highest case rate. We actually have the lowest at the moment, which is great after this having some of the highest in all of the previous waves, including Delta and last winter. So you can see in the gold there, that is the American Indian case rate. Then this is just new hospitalizations by age group, not stratified by, just stratified by age group, not adjusted for anything, but unsurprisingly, every age group, especially older ones, is spiking a lot and reaching these same kind of levels that we had last winter. I want to actually draw attention to the gold line on the bottom, which is pediatric hospital admissions for COVID. And it's easy to kind of dismiss that because it looks really small in comparison, and it is to the other ages. But you can see a pretty significant increase, kind of a bump right there that we didn't see with previous waves. So that's definitely something to consider, especially since we still don't have and aren't that close to getting a vaccine for under 5s yet. This is another way to look at hospitalizations and how that state is in the country. For ICU occupancy, we have, you can see in the orange is the COVID-19 ICU occupancy, and you can see it's kind of reaching where we were with Delta. I believe overall inpatient occupancy for COVID has already exceeded where we were last winter, but I don't have that slide, but it's from the same data source, which is Johns Hopkins University. And I actually included, you can see 82% utilization at the moment, which is quite high, and average utilization just as a comparison. I apologize if I'm going fast. I'm trying not to take up too much time, but I'm always happy to return to the slides if we have questions later. So this is another look at hospital capacity in the country. This is a really cool project that is looking at circuit breakers, essentially. So looking at what hospitals are at capacity and which ones are forecasted to exceed capacity. You can kind of see an idea on the national level, but I zoomed in on our region for USET at the county level. And you can see there's a lot of variation. So some places in Maine seem to have capacity, for example, and others say they're unsustainable. And that has a lot to do with just rural hospital capacity. And you can actually in Maine, those are, for example, just because I'm in Maine right now, those are like the city regions. So those are hospitals in the more populated areas seem to be the ones that are saying that they're unsustainable, which is concerning. And I wanted to bring this up as a point because anecdotally, we've been hearing from our providers and our health directors at the health committee call yesterday that they're having difficulty just transferring their patients to facilities anywhere, you know, whether you're in Maine or you're in Mississippi. And this does back up what they're saying. It's definitely an issue right now. And will probably be increasing as hospitalizations increase a couple weeks after usually COVID cases rise. Similarly to hospitalizations, deaths are like a lagging indicator of the COVID situation. So I included this just to compare to where we were when we met last, but it's probably not going to, we're not really going to see a true picture of Omicron's effects for a while. You can already see a spike though, and we are back to about 1,600 deaths per day as a 7-day average. And that's a 44% increase since last month in December. I'm actually switching gears a little bit here because I wanted to talk about why this is happening and, you know, what traits Omicron displays that contribute to these huge like increases in cases and hospitalizations. Specifically, I really appreciate this from the UK Health Security Agency. They break down what we look for, or what we look for as indicators of a variant's kind of concern, or whether we're going to classify them as a variant of concern or interest. So these are 4 indicators they would look at to say, you know, this variant is actually a problem or not. At the top, growth advantage refers to different things, but I will be talking about transmissibility and immune evasion, and those both contribute to growth advantage. So those are 2 factors that contribute to why Omicron is the dominant strain at the moment. And before I get into those, I also wanted to note infection severity at the bottom. I think for sure, data now does show there's increasing evidence, and we've all seen headlines, you know, that Omicron is milder, so on and so forth. And I just wanted to note here that often in those headlines, in these conversations, is the comparator is left out. And it's important to note that generally that's in comparison to Delta. And Delta was extremely severe. It caused very severe disease, and much more so than previous strains. And just because Omicron is milder doesn't mean that it is mild, which is especially for unvaccinated people. And that is what we are seeing right now with, you know, increasing hospitalizations, increasing ICU admissions, et cetera. So definitely not to be discounted just because it's good news it's milder, but not to be discounted. And moving on to transmissibility, specifically, this is looking at how long you're likely to be able to transmit that virus, and a proxy or a good idea of that is looking at incubation period, or how long since you're exposed, how long does it take for you to like get a positive test or experience symptoms. I'm actually also looking at this specifically because these 3 studies in gold are the 3 studies that the CDC cited for why they changed their quarantine and isolation guidance to 5 days from 10 days previously. So their basis was these 3 studies in Nebraska, Norway, and South Korea that showed a much shorter incubation period for Omicron than previous variants. So with Delta, your median, you basically experience symptoms by day 5, and you'd be infectious before and probably a few days after. For Omicron, they're presuming based on this data that you're going to probably show symptoms by day 3 or day 4. However, I want to make 2 points, maybe 3, maybe I'll make 3 points on this. They're very small studies, which is to be expected since we have, honestly, this happened very fast in the last month. So we don't have a ton of data, but the data we have is just limited. They are done in populations where they're either highly vaccinated or had, for example, in Nebraska, history of previous infection. And we know that people who are vaccinated or previously infected may not be able to transmit as well or as long as others. And then finally, there was a huge range, not a huge range, but there was a large range up to 8 days in which people for an incubation period. So there is the possibility of transmitting outside of that 3-day median time. And that is backed up in 2 other studies. I know there's one from Taiwan as well, but I didn't read through that one, so I didn't include that here. But in Japan, they found a longer incubation period and a very large range up to 10 days when you may be able to transmit this. And in the UK, they had a modeling study where they found 10 to 30% of cases were still capable of transmission after 7 days. So all of that just to say that it is a pretty early, in my opinion, to change the guidelines when we're not actually sure. And many people, even if a few people can still transmit after 5 days, that can make a big difference in a small community, especially some of the communities of our tribal nations. So important to note. And then I'm going to move on to immune evasion. So immune evasion is basically how well does previous existing immunity protect against a new infection or reinfection. So existing immunity is either like infection induced because you had COVID before, or it's vaccine induced because you're vaccinated. Pretty self-explanatory. And I am not talking about reinfection too much. There's a lot of lab studies that go into reinfection, but I only included the 2 real world studies here. So one study from South Africa that found a 2.39 times greater risk of reinfection than first time infection. And then there was a study from the Imperial College London that found a big risk of 5.41 times higher risk of reinfection with Omicron versus Delta. The lab studies have shown something similar, which is that the previous infection isn't as protective as it used to be against getting Omicron. Then on a similar note, vaccine effectiveness, as Dr. Brown mentioned, against infection is basically not effective at all if you have a 2-dose series, or I guess a 1-dose, although that's not really been measured. Symptomatic infection and hospitalization effectiveness has also been greatly reduced. And the studies I've seen are mostly from the UK, and the one I'm going to show in a second is from the UK. So they only use the 2-dose AstraZeneca or the 2-dose mRNA Pfizer or Moderna vaccines there. The good news is that a booster dose is actually still really effective. It does work really well, even against symptomatic disease. And it was up to 88% effective against hospitalization. There's a few numbers depending on what population you look at, but between 68 and 88% effective. And that's what this slide shows here. So on the left is if you received AstraZeneca and you were boosted with Pfizer or Moderna. And then on the right, you can see if you were, if you received Pfizer and you were boosted with Pfizer or Moderna. So marked, really drastic reduction in effectiveness. The little gray circles are Omicron and the black squares are Delta. So you can see a huge difference. Pretty much zero for AstraZeneca and Pfizer after you've you're 6 months or more out from your second dose. The good news, like I said, is if you look at those second panels in each slide, each graph, you can see the boosted effectiveness. So for Pfizer, there's like a 60 or so boost. In AstraZeneca, and actually about the same for Pfizer, although, yeah, for Pfizer as well. And then Moderna also boosted to a high effectiveness against hospitalization, symptomatic disease. So this was specifically symptomatic disease. And then that 80 to 88% I just referenced was against hospitalization if you were already symptomatic. So still working really well with the booster, which is great to get us through this wave at least. And the reason I bring all of this up with reinfection is just that that immune evasion is the concerning property with Omicron. It is clearly our existing strategies aren't really working as well as they were for previous variants. So I'm not going to speculate on what the next vaccine will be, but we may need to, consider an Omicron specific one, like the kind that Pfizer or Moderna is working on. But clearly this is a contributing factor to why cases are increasing. It's not just unvaccinated people. However, I know there's a lot of studies that have shown still that unvaccinated people are still the people who are ending up sicker. So this is still providing protection. And I wanted to end on that note and then switch gears again to our recommendations for testing and isolation quarantine. So our recommendations are based on the information I covered, where we have two concerns. One, that it's premature to shorten the isolation period while we're experiencing a wave of an extremely contagious transmissible variant. And two, because many of our communities in our tribal nations are more vulnerable and are smaller, and transmission can occur more easily. So it's an alternative. We wanted to provide an alternative to the CDC's guidelines that are more specific to tribal nations. So for that note, we are recommending continuing that 10-day period. So if you were exposed by someone who has COVID, that would put you in quarantine, and you can isolate and stay away from others, monitor yourself for symptoms, and you could test. So you should wait till day 5 to get tested if you're using like a rapid test, because that's when you will most likely have the highest viral load and detection is more possible. And if it's negative, you can just finish your isolation, your quarantine period. If it's positive, or if you get a positive PCR and you're asymptomatic, then we recommend following the isolation guidelines. So over here on the right, those are our isolation guidelines. So we're recommending, again, 10 days if possible, starting at day 0, which is the first day of symptoms or the first day of a positive test. Masking with a well-fitting mask. I know that IHS was saying they still have N95 masks available. So that's, if you can't find them like in your local community, definitely reach out. And then medical attention, of course, if you're having concerning symptoms. So isolation can be ended after day 10 if symptoms are improving and you've been without fever for 24 hours without using fever reducing medication. So that's the same as the CDC's recommendations have always been, just with that longer isolation period. And speaking of testing, we do highly recommend the use of testing for COVID-19, especially the use of rapid tests for like routine testing and surveillance. There's the first point speaks to travel. So departing and returning from a trip, you might want to test before and after. I know if you are using like if you're flying, you would need to test anyway. But we recommend just in general, if you're using public transportation, I don't know, like a bus or a train or something, you might want to consider testing or testing frequently, more than the CDC recommends. If you are flying, you might want to test like 2 days out. If you are experiencing symptoms of COVID-19 or were recently in contact with someone, that's where we talked about you would want to go into quarantine and you would want to test on day 5 if you're using a rapid test, or get a PCR if you have access to one. If you work in a high-risk environment where exposure to COVID-19 is likely or frequent, I know a lot of hospitals do weekly testing. You might want to do that more frequently with Omicron if you have the ability to. Regardless of symptomology and vaccination status, if you're planning to meet with others, especially a large gathering or family, or where you're meeting with vulnerable people, which includes children who can't get vaccinated, or people who have existing conditions, like the kind that Dr. Brown mentioned, which is a lot of people. A lot of those are very common. You might want to test beforehand. We highly recommend testing. Like I try to just monitor myself and symptoms if I'm meeting with my grandparents. So yeah, at-home tests can be conducted before attending large gatherings and having home visits with friends and family. And so we have our quarantine and isolation guidelines to follow up. If you have a positive result, you would be able to follow those. And that is the overall gist of the recommendations. We will be releasing both of those documents as well as an FAQ to kind of address any other concerns that people are having frequently. I believe we're aiming for the end of today to release all of that. So you'll get an alert. And of course, you can ask us if you have any questions, please reach out. We are well aware that this is very, there's a lot of new stuff coming out from us and the CDC. So please reach out if you have any questions. And I'm just going to leave this up as the key points, just so we can end on kind of a positive note. I don't have anything else. So thank you.
There was a question in the chat from Shayla, and I'm going to read it. We've been discussing whether we are creating close contacts by releasing COVID positive individuals before day 10. Quote, modeling data suggests that close to 1/3 of persons remain infectious after day 5 and can potentially transmit the virus. What is your take on this? And I'm guessing this is for Emily and Dr. Brown.
Sorry, I'm just going to read through that. So that's a test to release question, right, Dr. Brown? I believe we are going to not recommend that at this time.
Right. I think also she's getting at the new CDC recommendations that say you can, isolate for 5 days and then you can go about your business as long as you wear a good mask the next 5. And your point about almost a third of people still being positive on day 6, that's the whole reason that we decided to go with just stick with the original 10-day thing. You can argue this whole thing different ways, and I don't think the CDC is necessarily wrong in what they're advising. I'm not saying that. I just think that it's also very reasonable to be more cautious and take that full 10-day quarantine period or isolation period. And also, as far as a test to release, that testing okay, so let's say you're in quarantine, you had a known exposure to somebody with COVID-19, a close contact. The reason that you can test at day 5 is if you test before day 5, it's likely to be negative, even if you are infected and you're brewing that infection. If you test at day 5 and you're negative, it doesn't mean that you're still not gonna, become positive sometime in the next 5 days after that, day 6 to 10. The reason that you could test at day 5 is if you are positive at day 5 and you fell into one of those high risk categories, then you might want to try to get one of the the only effective monoclonal antibody at this point is sotrovimab, or get the new paxlovid drug. Or if that's not available, you could consider 3 days of IV remdesivir or Malnupiravir. So that's the real reason to test. It's not that you test on day 5, oh, it's negative. Well, I'm fine. I can go out now. Don't have to wear a mask or anything. I hope that was a clear answer. This is all pretty complex, and that's why we're saying that if people have individual questions that you want to discuss with us, we'd be happy to discuss those. But I agree that saying, 5 days and well, then you're okay to go out with a mask and do whatever. One thing is I see people wearing masks all kinds of ways, including, on their chin, and they're not very effective when worn on the chin. Due to the fact that people don't, in my opinion, there's a lot of people that don't wear masks correctly. I think just saying, oh, okay, after 5 days, just wear a mask is probably not a good strategy in situations where you're really trying to prevent spread, especially to vulnerable people. And I think Bernice had a question too. Yeah, Sheila, you're right. Yeah, 2 years and people still wear them incorrectly. Let's see, Bernice had a question. Your concern is that with the increase of hospitalizations in babies under 5, does the Omicron variant seem more dangerous than previous variants? And do we know the true severity of this variant? And a lot of us do have young children in the home. I think we're really at this point, it's kind of concerning, the data that Emily showed us with right now we're having the highest rate of hospitalizations in that very young age group that we've had during the whole pandemic in the US. So that's kind of concerning. And I think it also gives pause to say that, well, this Omicron variant, it's not that bad, it's just like a bad cold. It's still killing people, and it's still putting little kids in the hospital at an alarming rate. So I don't think we need to take it lightly. I don't think we need to be terrified. We're a lot better at dealing with COVID, I think, at this point. The death rate is lower now than it was at the beginning of the pandemic, in part because I think we're better at treating it. We have things now that we can do for it. part of my professional work is as a hospitalist at the Cherokee Indian Hospital. And I think for hospitalized patients, things like high flow oxygen, which is a relatively new modality, the use of dexamethasone in really sick people, the use of some of the other immune modulators like baricitinib, Remdesivir probably helps. It certainly helps early in the course of the disease and may help, with really sick people later. So we have monoclonal antibodies now that we're giving to people, although we've lost 2 out of the 3 monoclonal antibody treatments to Omicron. So we're better at treating it, but this is still a serious disease, and I don't think we need to take Omicron lightly. Certainly don't even think about having, going to an Omicron party. That's if you want to, you want to play Russian roulette. I think that's what you're doing if you were to, knowingly expose yourself. So don't do that.
And to add to that, while we don't know, Bernice, whether it's severe illness, like the kids that are getting sick are sicker than kids before, or if it's just the fact that so many people are getting Omicron, that those numbers are going to jump anyway. But regardless, if there's so many hospitalizations, as we've already seen, and so many places are reaching capacity already, it's going to be hard to get quality care, even if theoretically we know what we should be giving people, to no fault of the healthcare workers. So yeah, definitely don't go to an Omicron party, but in general, it's that is why we're trying to take this more conservative approach.
I think that's a really good point, Emily. And I can tell you from my experience, when you try to get somebody transferred to a place that has an ICU, which we don't have at Cherokee, it's nearly impossible right now. Yeah, don't get sick. Try not to get sick. I think there's another question. Has USET issued this recommendation to all USET tribes? Yes, we are. And again, we strongly believe in tribal sovereignty. So if your tribe makes a different decision, that's entirely up to you. This is just what we're recommending based on the fact that Omicron is very transmissible. It's not totally benign. And, we have seen during other phases of this pandemic that Native people have been really hard hit. And we want to try to prevent that if we possibly can. And so that's why we're going with more stringent, or if you will, more conservative recommendations.
Hey, Carrie, you can unmute yourself and ask. Go ahead.
Thank you. Good afternoon, everybody. Dr. Brown, thank you for everything. Emily, thank you for what you've reported to us. I have a couple of questions. Dr. Brown, do you think that those of us who've had our booster are going to be looking at getting a second booster, say 5 months after we had our first booster? And do you think that by flu season, there may be a combined vaccine?
I'm going to go out on a limb and speculate that the answer to both of those questions is yes.
I'll take that.
I think we probably will be seeing, a recommendation for an additional booster dose.
Okay.
And I am hoping that by next winter, there will be a combined COVID flu shot. So, one shot cover both of those serious respiratory illnesses.
Mm-hmm. Okay, I have another question based on the USET recommendations, and I'm very, very happy. Those are coming out today, you said? Connie and I are Connie and I are pretty anxious to get those in our hands, as the tribal council has already gone with the CDC recommendations. But I guess my next question would be, and this might be very far reaching, is IHS or the Nashville area office willing to support that USET decision as well? You know, sometimes with councils, they're driven by different motivators. Not that they think that USET's any less of an organization than IHS is. I certainly don't. But just looking for that maybe increased support for that recommendation. Connie and I are in 100% agreement with you. So.
Well, I can't speak for the Indian Health Service or for the Nashville area office. I can say that it's always been my experience that the Indian Health Service is a strong supporter of tribal sovereignty, at least, you know, in recent years. Yeah, maybe if you go back a long ways, that statement might not be true, but I think at least in recent decades, they have been very supportive of tribal sovereignty. I can tell you off the record that we've had conversations with Nashville area office, and they, while, you know, they can't I think they would really be going out on a limb to issue official written guidance that differs from the CDC, because they're both federal organizations. I can tell you that off the record, they don't disagree with us. How's that for being?
I kind of knew, but I just thought I'd ask. It was a reach, but thank you. Thank you.
Yeah, I'm trying to walk a fine line here, but don't want to speak for my federal colleagues, but I think they would be supportive of you if you went with, you know, the recommendations that we're advocating.
Yep. And you know, on another note, real quick, I really think they should have kept it at the 10, because it's very different from place to place. You know, daycare centers, trust me, they're still running on 10 days. I don't think my daughter's had a full week of work in 18 months because, you know, one kid is a close contact. You can't be in there for 10 days. The schools have gone to 5, but you can still come to school. Here, and unfortunately, I have 6 people that work with me in PRC, and you know, we've been masked since January 3rd. I kind of implemented a PRC mask mandate, thankfully, because we, all 6 of us now, are a close exposure to somebody who is out positive with COVID from our Monday test. And that's the rule here in the building is, and it is a mask mandate in the building now, our building, which is good. But if one of us, you know, at work, close contact, you test every 3 days, you wear a mask, you don't eat in a congregate area, you know, so we're following those rules. So we've all taken our second test. Today's Friday, yesterday morning. I'm not going to be eased until my next Monday test results come back. I won't see you for a few days. But
yes, my wife had a close contact Saturday a week ago. She did do a test this morning that was negative. You know, we're both glad, but we don't feel like we're perfectly safe yet. So yeah, we've been both quarantining at home. And of course, the problem is you don't find out that you're a close contact until, you know, she didn't find out about this until Tuesday, and the close contact happened on Saturday. So, and as fast as, you know, the Omicron incubates in some people, you know, that was great information that Emily went over with the incubation period. But, you know, you can be sick before you even know that you were exposed, basically. certainly can be contagious before you know that you were exposed. That's why this virus is so good at transmitting. It's that you can spread it before you know that you have it, before you know you're sick. And that's why what you're doing there with the serial testing is probably a very good idea.
Any other questions? Again, if you do want continuing medical education credits, I shared that link for the evaluation you have to complete. But if no other questions, you can go ahead and end this. I'm going to stop recording.